Wild Health is about optimizing you. We use genomics, blood work, biometrics, microbiome assessment, many other tests, and a conversation with you to come up with a full health optimization plan. What's the perfect diet, exercise, and supplement plan for you and only you? The Wild Health podcast is about optimizing all of us. Here we cover the cutting-edge science that gives you the base to be able to apply the personalized plan we give you as a patient. To sign up as a patient, go to wildhealth.com. Or if you're a physician or health coach and you want to learn how to do this for your patients, we're happy to help as well. Wildhealth.com for all the information on becoming a patient or working with us.
All right, what's up, guys? It's Erin Faules back for the podcast, and I have Jeff Graham with me today, our medical director, dear friend of mine, and an awesome human. We are going to be talking about the last of the three-part series for the blocks to our Healthspan. So we've run through a lot of them so far, but today we're going to be diving into, to kind of close out this series, we're going to be diving into neurodegenerative diseases and metabolic dysfunction. So Jeff is one of our experts in precision medicine and performance training, and excited to dive into it with them. Good to see you, Jeff.
Good to see you too, Erin. I don't feel like it's been that long, and we're super lucky. We just got to have an offsite together and actually play with your baby and give each other a hug. We don't get that often, you know?
I know
It's
it's
fun.
the downfalls of a virtual company, but it's super special when we all get to get together, even if our CEO plants it at 11,000 feet, and a few of us get altitude sickness.
Uh, I know. I was worried about a couple of our folks there for the first 2 days for sure, but it ended up being a blast. Yeah, for
Uh,
sure.
anyway, so I'm super excited to dive into this. I think metabolic health and dysfunction and insulin resistance has gotten a lot of buzz recently, but I'm not so sure everybody is aware of what neurodegenerative disease means. So, how would you break that down to people? Like, what does this actually mean in kind of layman's terms for people? What falls into this category?
Yeah, it's interesting because as I was preparing a little bit for this podcast, I was thinking about, we all expect to get some cognitive decline as we age. We don't seem to, the brain ages like the rest of the organs in the body. So there is this kind of distinction around what we think of as normal aging, and maybe not remembering things quite as well. And then what we actually call disease. So really under the category of disease, we're talking about Alzheimer's. We're talking about Lewy body dementia. We're talking about Parkinson's and frontotemporal dementia. Those are the four big ones that I think of when I think of neurodegenerative disease. So they actually start, what I like to, the way I distinguish it personally is thinking if the physical body is not yet showing signs of failure, but the memory starts to go away, then we need to start getting worried. The problem is that they tend to start much earlier than our medical system than you and I were trained originally to actually start picking these up. So they can start 10 to 20 years before we actually begin to see symptoms. And now, thankfully, we're starting to have some technological advantage there where we can actually start to look for things before we see the impact of cognitive decline that are kind of warning signs.
Yeah, so this is the tie into so many of these blocks that we've talked about, right?
Yeah.
Cancer, cardiovascular disease, now neurodegenerative, and even metabolic dysfunction in a way. Like we just catch things late, right? And
Yeah.
especially with things like dementia and things like heart attacks. I mean, the stakes are so high, right? So early detection with some of these newer technologies, and some of them not so new, but
Yeah.
bringing them kind of to the forefront of detecting these things early enough to actually be able to do something about it, right? Rather than
Yeah.
just playing defense and picking up the pieces. Um, Awesome. So like say a patient comes to you and they've got, a family member that's struggling with dementia or some sort of neurodegenerative disorder, and they're concerned, or maybe they have a big risk factor in their genetics that we look at. Like, how are you going to approach this patient differently, than you would, even if maybe they're not having any symptoms yet, maybe they're not having no memory decline symptoms yet.
Yeah, so they're not having memory decline symptoms, but the family member is worried. The
Like,
patient themselves
they're
is not.
they're at risk, they're worried, they wanna kinda
Yeah.
prioritize this.
Yeah. I mean, I think it's going to kind of be cheating ahead to the second part of, I think, what we're discussing today. But the very first thing, and it's appropriate that we're discussing these together, that I'm going to look for is metabolic disease. Because we know that, I mean, a lot of people out there, hopefully a lot of our listeners are familiar with this new term that a lot of people are using is type 3 diabetes, which actually presents with things like cognitive dysfunction because it basically means there's metabolic dysfunction in the brain. So I think about screening for things like fasting insulin, high sensitivity CRP, looking at your A1C, your fasting glucose. We go a little bit deeper at Wild Health, as you know, by looking at methylation markers like homocysteine, B12, looking at their omega-3 index, which are super important for a healthy brain as we age. So, those are kind of my starting point, what I'm going to start screening with, because oftentimes if someone is not been diagnosed with metabolic dysfunction yet, and we can just work on correcting that, brain function gets better.
Yeah, that's awesome. And I mean, you would think those things would be tested pretty widespread because 'cause they're quite frankly so cheap and easy. Um, well, simple. Easy maybe is
Simple.
different.
Yeah. Yeah.
I like to make that differentiation when it's lifestyle.
Yeah. Like my
Because
daughter's
habit
kindergarten. Yeah. Like her teachers say, we don't say it's easy. We say it's doable.
yeah. Lifestyle change is hard. We have habits for a reason. But,
Yeah.
we can look at things and get a pretty clear-cut idea of some of the major risk factors, like you're saying, that lead to these things, right? So,
Yeah.
and a lot of people, most people, I would say, coming to us, even when they're very health literate, haven't had a lot of these things tested previously because it's just not super pervasive in our current medical culture to do so. So, like keeping it foundational, keeping it affordable, um, people can ask their regular primary cares if they're not Wild Health patients for these kinds of tests pretty easily as well.
Yeah.
Um, and then, there's kind of more advanced technology. Like you said, technology's come a long way in terms of doing a little bit of a deeper dive to risk stratify for these patients. Is that something like more advanced type of imaging as an example for brain health? Is this something you're using? I mean, it's obviously not something everybody's going to have access to in terms of finances. But just kind of curious what your thoughts are there on some of the more kind of advanced technology here.
Yeah, 100%. I kind of think of that more advanced workup. If we're thinking about imaging specific, we can look at PET scans, which we've used for a long time, for looking, kind of detecting cancer and then managing cancer as we're going along to look at the response to treatment. So we can use that. We can also use what's called a neuroquant MRI, which is a specialized MRI that looks at specific regions of the brain that we tend to see wasting earlier with cognitive decline diseases like Alzheimer's, like the hippocampus. So if we see kind of a disproportionate loss of hippocampal volume compared to the rest of the brain, we've got a really big, that really increases our index of suspicion that this is indeed what's going on. Like you said, that technology is not available to everybody, and insurance is usually not going to cover that. So if that's not an option for some of my patients, we do take a little bit deeper dive, some of these markers, right, that we've talked about recently, the new markers that are available in blood that used to only be available through a lumbar puncture or spinal tap.
Yeah, through CSF.
Yeah, in the CSF. So now we're able to check things like phosphorylated tau or p-tau is what a lot of people know that by, and specifically 217 is one of the most sensitive early markers of tau pathology. And for our listeners out there, I think we're doing a good job at sending this message out, but the amyloid plaque that was kind of a red herring, right? That was what we saw further down the road. And I think even the scientist, I can't remember his name right now, who authored that and said, this is a problem. It's amyloid plaques. He's come back and said, hey, I was wrong. That actually is not the problem. It starts way before that. That's kind of the end result. But we look for these tau proteins earlier. So that's where this phosphorylated tau test comes from, because it is an earlier indicator of what we're going to see as impending plaque buildup in the brain that's going to accelerate to full-blown disease. And NFL is another one, neurofilament light chain, and it really tells us about neuronal damage. So I think about those two specifically. Yeah, and we can check those in the blood now.
And those are going to be, not super cheap, but much more like attainable, I think,
Yeah.
than something like a neuroquant MRI or PET scan for sure,
Oh,
in
yeah.
terms of cost,
Yeah.
analysis and in kind of attainability for your average person. So, I love that those are able to be, attained by hopefully a broader group of people now.
Yeah.
Pretty traditional lab groups are have these as options now, which is pretty cool. Um, awesome. So these are going to tell us kind of early disease, that early detection that we talked about. Let's talk a little bit more about like how we know who we should be doing these tests on, right? Like one, maybe with a family history, but how do we risk stratify like who are the high suspicion folks? Like how big of a role do genetics play as an example here in your practice?
Yeah, genes can absolutely be huge. And I mean, I guess I didn't even mention at the beginning. I mean, you know this, but we've been using things like the mini mental status exam, the MOCA exam. There's actually this really cool, I know we've been talking about forming a official relationship with the CNS vital signs recently, where you can kind of test yourself online and just give yourself an objective score. And I find for my patients, that's most useful if we're thinking about this, maybe we start a workup and I kind of have them do that serially throughout their journey with me so we can watch and see if that score changes progressively. It often won't, but it's a good screening starting place. So, um, but yeah, I think when you're talking about genetics, I mean, the ApoE4 gene is the biggest thing. I think it's probably the most famous gene in the world at this point. If it's not, it should be because it's something that can increase your lifetime risk of Alzheimer's by up to 12-fold if you have two copies of it. If you have one copy, we think of it probably doubling, maybe probably tripling that risk. So as you know, women, as you know, unfortunately have a slightly higher risk of Alzheimer's lifetime, but men and women, I think of somewhere in that 8 or 9% range. If you have one copy of an ApoE4, that automatically accelerates your range up into the 20s somewhere. So that's what I feel like it's really important to identify that first. And if I see an ApoE4 with one of my patients, it kind of reframes my entire set of goals with them. Okay, this is what we need to focus on now. And so then we look at other genes like the brain-derived neurotrophic factor, COMT, MTHFR, because those are all super important in how I think about the brain doing work and how it's able to recycle neurotransmitters. And oftentimes, if someone has a couple of risk alleles there, doing things that we know improve the, say, production of brain-derived neurotrophic factor, really stressing that early in someone's journey is going to help decrease the risk a lot.
Yeah.
Optimizing B vitamins to help with methylation is going to help them a lot.
So for people who aren't familiar with BDNF or brain derived neurotrophic factor, like Jeff's saying, I mean, this is going to actually, when you increase this, this is going to actually increase your brain's neuroplasticity or
Yeah.
the amount of your brain's ability to actually like grow new brain cells essentially,
Hmm.
which
Hmm.
is super rad. Lion's mane can increase this to a small
Right.
degree. Has gotten a lot of buzz. Probably the best way to increase it is exercise. So some people have like a more robust response to that than others, but one of the reasons of the many reasons exercise is so powerful. Hit training
Super powerful.
specifically, right?
Yep.
Is really powerful for this. Yeah.
Yeah.
So that's pretty awesome in terms of, like, actionability there, and, yeah, we definitely check ApoEs in our patients and can be kind of a game changer in terms of kind of triaging levels of
Yep.
focus, like what you
Yeah.
said,
Exactly.
and some people come to us because they know they have an ApoE risk allele, and they're like, "I know I've got an ApoE4, what do I do?" And they're not sure kind of what to do with that. Maybe they've gotten a 23andMe or something else, and, they know they have this risk allele or 2 copies of it, and they, are nervous, understandably so. And
Yeah.
and the cool thing is there have been some studies on ApoE that show that when lifestyle interventions are put in place appropriately, you can reduce your risk to near baseline
Yeah.
risk for dementia, which is great. So it's not like it's this, deterministic like sentence, just like all that we do with epigenetics. But it does. I like to tell people like when we look at gene SNPs, we have areas of kind of natural strengths and natural vulnerabilities. We all have those categories, and how do we kind of leverage and optimize the strengths, and how do we best support the vulnerabilities, and just hedge our bets there. Kind of when the risk of outcome can be high, like why not, right? So
Yeah. Yeah. Exactly,
Cool.
exactly. Yeah, I think the other thing, then you mentioned exercise. I know you're going to ask about, how this works in with metabolic disease in a second, but I think one thing we don't want to leave out of this discussion is the importance of sleep.
Yeah,
Um,
for
you
sure.
know, there's just no better time, and I know you do this with your folks too. But if you see an ApoE4, that is an automatic trigger for me to be looking at really optimizing someone's sleep and have them take that very seriously. A lot of times diet can help us do that, timing of food, different supplements like magnesium can really help improve quality of sleep. So that's usually a big focus for me with this population as well.
Yeah, I cannot unlearn the term glymphatic system from medical school.
Yeah,
When
yeah,
we sleep, we go through lymphatic cleanup, essentially, or clearance. Our glymphatic system cleans up our brain and our
yeah,
CSF tissue, and it's essentially like trash day for
yeah.
your
It's taking
nervous
the trash
system.
out. Exactly. Yeah,
And it's just a word that sticks with you. But sleep is necessary for that, like good quality sleep, right? And we do a lot of that as well at Wild Health. Our health coaches are amazing. They'll look through your wearables with you, your Oura Ring or Whoop or Garmin or whatever you're using, and kind of like troubleshoot how do we really, really optimize not only like how many hours you're getting, but what's the quality of that sleep? What's your sleep architecture and are you able to like adequately heal and kind of promote that resilience? And if you're not sleeping adequately, spoiler alert, you're probably not. So awesome.
exactly.
So say we have someone with a high risk for one reason or another, like it's great to know that, or we have early detection and we know there's early disease, whether it's symptoms, whether it's imaging, p-tau, whatever. What are you doing with these patients, right? Other than, I mean, not to minimize the like multifaceted lifestyle approach that we've touched on, that's the most
Yeah.
important thing. But are there some other additional things you're adding to kind of the repertoire for these patients that are at additional risk? Like, what are the things you're really paying close attention to?
Yeah, I am not someone who I have messed around with ketosis myself and ketone esters, and that's kind of one of the things. It's not something I use all the time, but when I don't have any 4 allele. If I did, I probably would, because I do think that this is an area where a ketonic diet can have a lot of effect. The guy Chris Palmer at Harvard, is that the guy who's demonstrating you can reverse, the symptoms of schizophrenia through ketosis? And yeah, we just see this intense anti-inflammatory brain. And basically, if we think about Alzheimer's, as we've discussed, as a metabolic disease of the brain, ketosis is a great cure. So even if someone's not willing to adopt an entirely ketonic diet, these fuel forms, ketone esters, which are basically insulin independent forms of fatty fuel that the brain can burn and use, and the brain loves. They tend to lower neuroinflammation. I'll have them at least order some of those, and those can be super effective when taken like 30 minutes before a meal, just to blunt insulin spikes and glucose spikes during the meal. So using those a couple times, if not before every meal, a couple times a day, just to actually think about driving neuroinflammation down. Omega 3s are always a big part of my discussion with this group. We're looking for levels over, probably 8% when we're looking at those omega 3 levels. And then really, as we've talked about already, B12 tends to be a really healthy vitamin for the brain. And that kind of goes along with that methylation risk. I tell people, we think the brain probably does, close to 90% of its work through methylation processes. So if you can optimize your ability to methylate throughout the body, your brain, you're just going to offload work from the brain, keep it around longer.
Yeah, that's
Yeah.
awesome. And then,
Yeah.
um, this has come up in a number of our Healthspan blocks in this series. But what are your thoughts on dosing GLPs for these patients? If they've got an ApoE4 SNP, or do you have strong feelings one way or another? There's definitely some
You were,
strong evidence emerging.
Dr. Falls, you were baiting me so hard and you know it. You know I've been wanting to talk about this. Erin knows we just actually talked about this. We did a little presentation on their offsite. But yeah, I'm a big fan of GLP-1s with an ApoE4 risk at all. I think there's been some really interesting evidence come out over the last 2 years. We just talked about this huge meta-analysis that was done, came out in April in JAMA, They include like 160,000 some odd patients over 32 studies, and showed that out of the 5 medicines tested for glycemic control, they kind of did this spin-off group to look at cognitive decline. And the GLP-1s were the only class that really stood out over. It was almost a 2-year, no, almost a 3-year trial. It was 32 months that they that these studies were tracking, at least over that amount of time. Had up to like a 40% reduction in cognitive decline symptoms. So I think there's a lot of promise for them, as there's 2 other trials that are expected to come out later this year that are ongoing specific to this, called the Evoke trials. And I think once we have those results, if they look promising, this is going to be a field that a lot of people are going to start talking about and getting into treating with this for prevention.
Yeah, to put this in perspective for the listeners who may not speak this language and like peruse scientific literature regularly,
Yeah.
this is kind of unheard of in the neurodegenerative space. Like there aren't standard of care medication and treatment regimens for things like dementia that reverse cognitive decline. Like the
Yeah.
goal is to slow progression. That's always been the pharmaceutical goal kind of until now. There's kind of some newer stuff coming out that's promising. But this is so exciting. The other study I've ever read that shows reversal of cognitive decline is by Bredesen. And he's looked at as pretty controversial in the medical community, but gosh, makes a lot of sense to review different lifestyle levers like we've talked about. He looks at toxins, he looks at metabolic health, he looks at hormones, he looks at micronutrients, et cetera, vascular health, et cetera, like optimizing all those things. What do you know? People got a little bit better, right?
Yeah.
So
Yeah.
it's very similar to the way we do things. He's got
Yeah.
a really fascinating new book, The End of Alzheimer's, and he uses the RECODE protocol. It's like extremely nuanced,
It is
and
nuanced
detailed.
in a lot of steps. Yeah. But
Uh-huh.
if you follow
Uh,
it, yeah, I think it works. It's just, yeah, it's a heavy lift for a lot of people.
yeah, but it's always been a very sobering topic in
Yeah.
healthcare. I remember learning about this in med school and being like, wow, like there's so much money being thrown at this, and there's so many people looking at this, and like all we can do is like slow it down slightly. It's just always kind of really sobering, and a really devastating diagnosis that touches so many families. So it's so exciting to hear about a medication that potentially can take the edge off that. And if we could, I don't think there's data out there on this yet, but like we're kind of extrapolating that. And what if we take this for people that are just at risk or have super early detection before they have those symptoms? Like, what
Yeah.
could this mean for them later, right? And what are the downsides, right? Very little.
Yeah.
So it's exciting. Awesome.
100%. Yeah.
Awesome. Well, there's an obvious tie-in to jump
Yeah.
into metabolic health here. Like you said, type 3 diabetes, for neurodegenerative. So, I think this is a little more of a well-known topic. It's gotten quite a bit of buzz, insulin resistance, rightfully so in recent years. But how often do we address metabolic dysfunction in our day-to-day
Oh my
practices?
god. Yeah. I think it's kind of the curse of really looking for it hard, right? It's like if you turn over enough stones, and this is what differentiates us too, is that we do turn over those stones, and we'll pick up signs earlier than the conventional medical system usually does. So we talk about it a ton. I'd say every other patient, there's at least one of the kind of warning signs that's popping up in their labs going, okay, this is, we need to actually recheck this. We need to institute some changes right now, and see what happens in a few months to see if it changes for us. Um,
Yeah.
the answer is a lot.
Yeah, totally. And so what are you looking at when we're talking about metabolic dysfunction? Because we're not just looking at people with diabetes, right? Like that's kind of
Yeah,
the obvious one that comes to mind, in kind of the traditional medical world. But
yeah,
even then, I mean, we learned about metabolic syndrome in med school, right?
yeah, yeah,
Like there's more to it than just diabetes, right? So what
yeah.
all are you looking at in people?
Well, I think by the time that what we learned in medical school, by the time your blood sugar is 126 and your A1C is 6.4, as they say, the horse is out of the barn. Like that's the disease is there. So we're trying to catch it way before that. So we're looking at things like fasting insulin. Of course, we're going to pay attention to your fasting glucose, but we're going to look at a home IR score, which is a homeopathic assessment of insulin resistance. And it's basically putting together a bunch of different labs, including your lipids, to paint the whole picture for us, because metabolic disease has been, I think, misunderstood as just my sugar's high for too long. So we're looking at that. We're looking at your triglyceride to HDL ratio. That's been a long-standing early indicator. Your apolipoprotein B, and then we're looking at things like high sensitivity CRP, which we get standard with all of our patients when you come in. The other part of that kind of what we call metabolic disease, and that we want to, people to understand, and is why we do things like DEXA scans a lot, is that it really starts with the liver. So looking at, talking to someone about if they've ever had, looking at their liver enzymes first off, so looking at AST and especially ALT can give us some insight. If that's doesn't have to be really hugely elevated, but if an ALT is in the 40s or 50s, that should be a sign, if there's no other reason that the liver is working too hard. So that's really where a lot of this disease starts, and so focusing there first can give us a lot of advantage at deciding how deep to go with this.
Yeah, for sure. I mean, these are just foundational labs we check out the gate in everyone, right? Not only that, but we're looking at DEXA scans or body comp analysis to look at lean mass and visceral fat mass, right?
Yeah.
Um,
Oh, with
you know,
CGMs, we use a ton of CGMs too. Yeah,
yeah,
that's probably
exactly.
what
Continuous
I saw you
glucose.
smile and you're like, yeah, am I forgetting something? Yeah, of course I'm forgetting.
No,
Yeah,
not at
but
all.
continuous
I
glucose
just
monitoring.
we're just
Yeah,
looking at this all the time in our patients, right?
yeah,
Like
yeah,
I think everyone would benefit from a CGM, once a year or so to
yeah,
just see how your body's processing energy, right? Same thing with body comp analysis. I think it's a really, really good thing to measure. I mean, this is just such a pervasive issue and it is such a foundational issue that affects all of these other issues that we've talked about, right? Like it's going to massively increase your risk of cancer, of heart disease, of dementia, the list goes on, right? So, it's just something that is so, so, so important. And gosh, it was a 2019 study, I think, that made huge headlines because 88%, I believe, of Americans had metabolic dysfunction, right? And this is 2019. So this is
it was
before
6
the
years ago.
pandemic, which I'm
Yeah,
sure everything got worse. And
worsened it.
then,
Hmm.
not only that, but they weren't checking these early markers, right? They were checking A1C, they were
Yeah,
checking blood pressure and lipids, but they weren't checking a fasting insulin, which we know it, like you said, once you hit 6.4, it's just
it's
as arbitrary. Maybe it's not totally arbitrary, but it's a number we've decided is diagnostic of disease, quote unquote. But gosh, it starts so long before that, right? And so we want to catch insulin resistance before it even becomes an elevated A1C, ideally. And then we want to catch that well before it becomes prediabetes or diabetes. So imagine the number now, if you were to include those early detection analyses. So
yeah, 100%.
it's just,
And I
yeah.
want to say something so that the listeners hear this very clearly, because you asked me like, what, how about the ApoE4 gene? How much does that increase your risk? I want everybody to hear this very clearly. Your Alzheimer's risk, if you develop metabolic disease, goes up by a factor of 5. So remember, one E4 allele increases your risk for diabetes or for Alzheimer's by a factor of 3. It maybe triples your risk. If you develop metabolic disease and you're keeping it, especially through your 40s, 50s, 60s as you're aging, your risk for Alzheimer's increases by a factor of 5. So it's even a bigger deal than having an ApoE4 gene, whether you have 3, 4, 4, whatever your ApoE status is.
Yeah, it just points to how much, control we have over our outcomes with
Yeah,
our day-to-day lifestyle, right? Which hopefully people find empowering.
yeah,
It definitely can be viewed as such.
yeah,
So, I love I love it when I get a patient that's, not sure what to do, and they come to us, and maybe their A1C is really high, their insulin is really high, their inflammation, CRP is really high. And they're like, "I don't know what to do." I'm like, "I'm so excited because these are actually lifestyle numbers."
yeah.
These are numbers that are so influenced by our day-to-day activities that we can do we can do this,
That's what we do well.
this
Like that's our
this
wheelhouse.
is
Yeah,
something we can change and
yeah,
pretty quickly, all things considered, if,
yeah,
if you fall again, not simple, not easy, right,
yeah.
again, but it's exciting to me. I feel like those are the patients you can so easily take their health from, like, a 40% to a 90%, right? Um maybe we can't change an ApoE4. Lipids can be trickier to change with lifestyle for some people, cholesterol values, but gosh, like metabolic health is a lifestyle disease.
Yeah.
So it's very exciting. Genetics can influence, but
Yeah.
lifestyle is extremely influential there.
Yeah.
Okay, so you have somebody that has a little bit of insulin resistance. Maybe they're pre-diabetic, maybe they're diabetic, right? Maybe they've
Yeah.
got, and of course, when we're talking about diabetes in this instance, we're talking about insulin resistant driven diabetes. So type
Yes.
2 diabetes, or kind of used to be seen as adult onset diabetes. That's unfortunately no longer true. That's no longer as accurate. But when there's insulin resistance driving this, kind of what's your home run here? Like what really works the best? I know what mine is with patients, but what
Yeah.
really tends to work the best,
From a
like
lifestyle
if you're able,
perspective.
exactly.
Yeah, from a lifestyle perspective. I think, obviously, the very first thing, if they're not moving, we need to get you moving. That's as simple as it gets. And the beautiful thing about just going from sedentary to moving a little bit, we see the biggest changes in things like insulin resistance when you're going from flatline to 2 days a week. That's all it takes, is starting to get active 2 days a week. So really emphasizing movement, exercise if you can. um, I love lifting heavy things. And if you can begin doing some strength training, because we know that's important, probably more important for females, as we're going through our 40s and 50s. These are what I like to call like the buffer decades. Like this is the
Hmm.
time to build that muscle because it is our greatest glucose sink. It supports insulin sensitivity and it actually produces these things that are called myokines that can be anti-inflammatory for the brain tissue and the tissue all over the body. So it really, I think about, incorporating that and just meeting someone where they are. That's where our health coaches, how good they are trying to figure out, okay, what are the barriers? What can we get you to start doing? So I think exercise is huge. Obviously we're going to slap a continuous glucose monitor on and start looking at dietary trends and see whether we are, having these really high, what we call postprandial or post eating sugars and what might be triggering that. And the timing of those things, the timing of your meals throughout the day can have a lot to do with that, kind of trying to match up your meal times with your circadian cycle. I have a lot of success, I bet you do too, in really coaching people around more fasted time before they sleep. I think that helps a lot
Yeah.
with
Oh,
glycemic
for sure.
control. Yeah.
Yeah,
Yeah.
you're gonna see a pretty wonky sleep architecture and glucose reading with the CGM if you eat a big meal right before you go to sleep.
Yeah,
Your
for
HRV
sure.
is probably gonna be blunted and your heart rate's probably gonna be up as well if you're wearing a sleep
Yeah.
tracker. So
Yeah.
that's a big
Yeah.
one that a lot of people I think don't know about when they first come to us because it's super culturally like common to backload our calories, rather
Yeah.
than kind of eat in a circadian rhythm when the sun's up. Our society like schedule is such that people are busy, busy, busy when they first wake up, and fasting in the morning has become really popular. And then you finally get home for the day, and you're like slamming all your protein goals and
Yeah.
everything, after you work out or whatever it is, and that can be kind of easy to fall into that habit, especially if it's like the only time you're sitting down with your family or this or that. A lot of times I'll tell people if that's hard for them to get around for reasons that are important to them with their family, I'll say, okay, maybe it's not like a hard and fast. Maybe you don't cut it off if that's the only time you sit down with your family in the evening, right?
Yeah.
But maybe that's your smallest meal of the day. Like maybe you flip it to where your breakfast is your largest protein intake, where you're really activating mTOR, and like it's a super important time to have protein anyway. And then maybe you're going down in caloric size for each meal
Uh,
thereafter. So,
yeah. I had a
meet them
patient
meet
who
them where
had
they are, right?
exactly. I had a patient that had a lot of these signs we're talking about, and he's pretty new to me, but I saw him recently and his blood sugar had improved greatly. His A1C had dropped by like 0.3 of a point. I was like, what have you been doing? He said, well, I just remember that old saying, eat breakfast like a king, lunch like a prince, and dinner like a pauper. I was like, all
Oh,
right,
I've never heard that, but I like
that
it.
works. Yeah. I hadn't heard it either. So that sounds like fantastic advice. Yeah. So really
Yeah.
thinking about front loading those calories, as you're saying, and then maintaining, we hear a lot out there in the social media world about, 1 gram per pound of body weight a day. And you can get much more specific with that if we've got a DEXA and we can really use your lean mass to think about your protein intake. But this is where where it does become important to track macros, because we know that if you have at least kind of a low sustained, I think about it like a diesel engine. If you start out your day with a lot of protein and then you're maintaining good protein intake throughout the day, you're not going to have these periods where your sugar crashes because you had a bunch of carbs and you're going to be driven to binge all of a sudden and drive that glucose up to 160 during the meal. So I think steady and slow, consistent protein intake throughout the day is a really important thing to be focused on as well.
Yeah, I love it, I love it. And then this is a little less, typical, metabolic dysfunction that you're gonna see in the traditional, like, standard American culture and medical system, but I think with a lot of our patients, we see this pattern,
Yeah.
and I think a lot of people might have this and miss it sometimes too because they're checking an A1C and not checking fasted insulin before they come to us. But we see people with actually sometimes really low insulin levels and they don't have insulin resistance, but they might have kind of paradoxically really high average or fasting blood sugars. That's not always from insulin resistance. So that's something to be aware of as well. If you're looking at these numbers, and this is where a CGM can be really helpful and getting a little more data can be really helpful. I see this a ton in women, but I see it in a
Um,
good number of men as well, especially if they're stacking too many of these hormetic stressors. They're exercising, it's fasted, they're having caffeine, maybe they're doing a cold plunge in the morning, it's CrossFit, or it's like a lot of intensity going on, right?
yeah.
And there's a lot of cortisol drivers or stress hormone
Mhm.
drivers going on. And if you don't give the body fuel, it's gonna make it, right? And
Yeah.
so it's gonna raise your own blood sugar. So just as an aside, if you're somebody that has, you've got a elevated fasting or elevated average blood sugar, you think you're pre-diabetic, a lot of times those patients will come to me, especially women, and they're like, "Well, I keep having a high A1C, so I'm like, eating less and less carbs and I'm fasting more." And, they're doing all the things they've heard to do in the setting of insulin resistance because of their A1C, and it's kind of making things worse. So there can be situations where the like classic treatment for insulin resistance is not always the answer for an elevated blood sugar. So just
Yeah.
to kind of point out that there's some nuance there that we see in our kind of high performing crowd a lot.
We do. And I would agree with you that it tends to be just because of all the nuances that go on in the female body with hormones. I do think it's more common in women. They seem much more sensitive to that. So, yeah, something to
Yeah.
pay attention to for sure.
For sure. Yeah, I was gonna say muscle growth as well as the single most helpful thing I see for controlling blood sugar. So I was interested to see what you brought up first.
Yeah, no,
I mean,
I
it's
think,
it's an actual bank, right? Like
yeah,
it's
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 natural
where our
bank.
sugar needs to go.
That's right.
So
And I know, we get really specific with this. Not, going to a gym, lifting up a barbell or dumbbells is not for everybody. So I would say, to those people, we have multiple ways to get around that. We can start with body weight, obviously. If that's not even an issue, or just having a trainer is not your jam, or being part of a gym, we love using these EMS suits now because they tend to be really powerful drivers for muscle hypertrophy. So, these things like the catalyst suit, these electromagnetic stimulation suits, they fire the muscles in such a way just over a 20-minute period that they equal all you can do in an hour in the gym and lifting weights. So, if lifting weights in your thing, if you've got an injury, a bad knee, a hip, a back problem that just doesn't allow you to do some of this stuff we know is going to promote muscle growth, these can be really effective alternatives.
yeah, totally. And, if you are lifting weights, it's interesting, like, what different people see as strength training, and it might be strength training, but you often need that actual progressive overload. You need to really strain and stress the tissues, right, to put that
Yeah.
muscle on and gain strength and hypertrophy there.
Yeah.
Um, so that can be done in different ways. Appropriate form, taking your time with lifting,
Yeah.
right? An actual time under tension, maybe throwing a weighted vest on if you don't like lifting weights as an alternative. Rucking with the weighted vest, or in my case, I like to say I have an ever growing weighted
Yeah.
vest with my
You
baby.
do.
He's currently
You're s
21 pounds, but the ruck will get harder and harder over the next
It's gonna
year.
get harder and
Uh,
harder, girl. Yeah, for sure. Oh my
But
gosh.
anyway, there's a lot of creative ways, and I love the EMS suits as well, especially post-injury, or post-surgery for people. It's a really great way to avoid that muscle loss. Um,
Yeah.
but it's really cool. I mean, when you get muscle growth, you're just taking care of a lot of the other things for yourself. Like you're making your own work
Yeah.
easier, right? Because it's going to
Muscle
burn
is
fat for
medicine.
you. It's
Yeah.
going to lower insulin levels, like which then is going to further allow you to burn fat. So it's just a super super powerful organ.
Well,
Awesome. So most of what we do with insulin resistance and metabolic dysfunction is lifestyle.
mhm.
Are you using supplements? Are you using prescriptions? How do you typically handle that?
For sure. I mean, the most studied supplement of all time is always my first line here, unless there's a reason not to use it, and that's creatine. And actually, really, beautifully for this visit today, it's something that works both, we think, with Alzheimer's prevention and maintaining muscle mass. And I think those two are probably somewhat related in the way that works. I don't know the physiologic pathway, but yeah, just starting with 5 grams of creatine a day to help exponentiate any sort of resistance training or exercise you're doing, because it does help to accelerate muscle gain. Berberine is something that has been around for a while. It's kind of like, patients come to me and say, "Isn't that just metformin in a natural supplement?" Like, yeah, it's not quite there, but it works in a very similar way. It's a wonderful prebiotic for the gut as well. So I think about it as kind of a dual action thing. It's usually improving your microbiome at the same time that it's inhibiting AMP-PK, which is kind of what we're going for with it's activating AMP-PK, which is what we're going for with someone who has insulin resistance. So it's a really usually well tolerated twice a day supplement that can at least give us a starting point. Um, and then I have gotten more and more um, excited because I used some myself for a while and watched the CGM with inositol, myo-inositol.
Mm,
It's
yeah.
a great yeah, it's a great sleep aid. It got really popular in the polycystic ovarian syndrome literature because I think that's where they started seeing better glycemic control in that population that is already at a high risk for
And
metabolic
fertility
disease.
support.
And
Yeah.
fertility support, yeah, yeah. So, just because I did my N of 1 study and did watch my glucose numbers, on average come down by like 3 to 5 points while I was taking it, and my sleep
Cool.
got better. Yeah, so,
Cool. Yeah, I've
um
heard that about sleep.
yeah, yeah, it does, it works well. You dose it really high too. I started out taking like 800, I think it comes in 800 milligrams, something like that, and I just took 1 or 2 a night, and I started looking at the literature, and it's like, "Oh, they're using 5 grams a night?" Like,
Oh, wow. I
you
did not
can
know that.
go yeah, I don't know, I wouldn't advise anyone to start out with that, but it's maybe something to ask your doc about if you're interested in that. So, yeah, those are some of the supplements I think I've read off, and of course, Akkermansia, the probiotic that there was some really good literature. It came out 2 years ago showing that it can drop A1C on average by up to point 0.3 or 0.3 of a point, which is a big move. It's like a, daily average of 9 points lower in your glucose readings. So just using that probiotic can help too. That's kind of where I think about with
Yeah.
supplements. Yeah.
Yeah, for sure. Well, this was rad. I think the theme, so we've gone through like so many subjects in these three interviews. We look at these as kind of the top 7 things that limit health span for people that we see on a regular basis at Wild Health. So today we went through neurodegenerative and metabolic dysfunction. Previously, we went through atherosclerosis, mental health disorders, and then in the second part, we went through atrophy, cancer, and inflammation. So these are some big heavy hitters. I don't think I know a single person who hasn't been personally affected, either their own health or a loved one,
Yeah.
by something on this list, right?
Yeah.
Because it's these are just the most pervasive medical issues that plague our society. So I think some of the themes, I mean, early detection, especially for some of the super scary stuff here, is super critical. And sometimes using advanced technology and even simple labs, to
Yeah.
help with that, right? Like sometimes it's going to be a lot of money and sometimes it's going to be $4. So, early detection and not just waiting for that arbitrary number that we've decided in medicine is the diagnostic threshold. But why don't we catch this before it becomes actually clinically significant in terms of symptoms, right?
Yeah.
So this is true for the 2 we discussed today, but it's also true for most of the others on the list. Um,
Mm.
in terms of what do you actually do about these things? I mean, living your lifestyle in a way that makes them less likely is the top of the list, right? Um, Building a lot of muscle, keeping your blood sugar under good control, keeping an eye on your micronutrients, getting good sleep, eating whole foods. I mean, again, like simple, not easy, right? And then hopefully getting a team that can kind of tie all this together for you. And then there's also some exciting things on the frontier in terms of treatments that we discussed a little bit too. So thanks for coming on for kind of tying all this together. If I
Yeah.
missed plenty, please feel free to sprinkle in whatever else you want to add here.
No, I think you summed it up beautifully, and I think it's our wheelhouse. It's what we do here. We love to help people make these changes to take action, early, because I think like this whole series in my mind has focused on this idea of 30-year risk reduction as opposed to 10-year risk reduction, and that's what we're trying to do for people is really look early and make changes when it counts the most.
Yeah, let's get away from just reacting to
Yeah,
disease, right? Like let's try to
100%.
get ahead of it as best we can. So, and to our brave patients, honestly, this is what I say to people all the time. I'm like, this is hard stuff to look at. Like, it's not always easy to look under the hood and know what kind of the bigger vulnerabilities are for you.
Yeah,
So, I think people are super brave to be able to kind of look at this data and take action before it becomes an issue because it's kind of easy to bury your head in the sand. And I'm not even saying that's wrong. Like going through life and just
yeah.
not knowing, like, that's the right approach for some people, but I do think it's really brave to be able to kinda take a hard look at that, and take a little bit of ownership of outcome to the best of your ability.
Yeah, I believe it leads to empowerment. I think when we know better, we do better, and that's what I feel like our job is at Wild Health is to help you understand, and if we can offer help and in that doing better part as well. Hey, I bet we can make some small changes that are going to have a lifelong effect in your world.
Right, because then they're truly informed decisions, right? They're
Yeah,
not they're not decisions out of ignorance. I mean, ignorance can be bliss,
yeah,
but when you really know, then it's an actual informed decision you can decide what to do with. So, cool.
yeah.
Well, good to see you as
Well,
always, Jeff.
always, Aaron. Such a pleasure. I want to do this more often. Ask me back again.
Yes. Let's do it.
You're
Talk to you
doing a
soon.
great job with this thing. So yeah, let's keep doing this.
Thanks so much for listening to the Wild Health Podcast. If you want more daily health education, be sure to follow us on Instagram, which is filled with health optimization how-tos, grocery shopping lists, guided breathwork posts, myth debunking, and so much more. You can find us at Wild Health MD on Instagram.